Welcome to this cardiovascular system review on danger signals, covering critical conditions and important exam tips. Today, we'll cover abdominal aortic aneurysm, acute coronary syndrome, bacterial endocarditis, heart failure, and angina. Most patients with an abdominal aortic aneurysm, or AAA, are asymptomatic. If symptomatic but unruptured, patients may complain of abdominal, back, or flank pain. A ruptured AAA is suspected with acute abdominal pain, distension, and hemodynamic instability. Highest risk: older white males who are current or former smokers with hypertension. Initial imaging for AAA is typically an abdominal ultrasound. Acute coronary syndrome, or ACS, includes STEMI, and unstable angina. Classic presentation: middle-aged to older man with constant chest discomfort over 15 minutes. Pain is often squeezing, crushing, or heavy pressure, sometimes radiating to arms, shoulders, neck, or jaw. It can be provoked by physical exertion, emotional upset, or a heavy meal. Atypical presentations, common in women, older adults, and diabetics, include epigastric discomfort, nausea, and fatigue. The best initial diagnostic test for ACS is the 12-lead EKG. All patients with suspected ACS should be given 162 to 325 milligrams of aspirin to chew and swallow, and 911 should be called. Bacterial endocarditis, also known as infective endocarditis, has several risk factors. These include valvular abnormalities, for drug use, and recent dental or surgical procedures. It is most commonly caused by Staphylococcus aureus, streptococci, and enterococci. Patients present with fever, chills, a new-onset murmur, anorexia, and weight loss. Associated skin findings include splinter hemorrhages, petechiae, painful osseous nodes, and non-tender Janeway lesions. The first test for suspected bacterial endocarditis is a transthoracic echocardiogram. Older adult patients with heart failure often report shortness of breath and lightheadedness with minimal exertion. Symptoms like orthopnea and paroxysmal nocturnal dyspnea are due to excess fluid accumulation. Physical exam findings can include lung crackles, jugular vein distension, and an S3 gallop. Heart failure is categorized by left ventricular ejection fraction, HFrEF, mid-range, and HFpEF. Stable angina involves predictable chest discomfort, brief in duration, and relieved by rest or nitroglycerin. Unstable angina occurs after minimal activity or at rest, becoming more frequent, severe, or prolonged, and is not relieved by rest or nitroglycerin. Unstable angina differs from STEMI by the absence of elevated serum troponin levels. For exam tips: always rule out AAA in an older male with a pulsatile abdominal mass greater than 3 centimeters. The next step is to order an abdominal ultrasound and CT scan. Also, thoroughly learn the signs and symptoms of bacterial endocarditis. Thank you for watching this review of cardiovascular danger signals.